Good day, class, and thank you for attending our lecture. So, this would be our second to the last lesson for the finals, your Module 10, which will tackle about your tumor immunology. When you say tumor class, this would refer to neoplasms or the so called cancers or your so called malignancies. So we will tackle the immunology of the tumors class, or your cancers, neoplasms, or malignancies. So let's start. Now, tumor immunology class would basically cover the study of the relationship between the immune system and the different cancer cells. Areas of concern of tumor immunology would include number one, the antigens associated with your tumor cell, the host's immune response to tumors, mechanisms by which tumors are thought to escape these responses. That's why class yung cancer is very difficult to treat because they have certain mechanisms or processes where they can easily evade or they could escape the immune system's ability to kill them. So later we'll tackle that more. Then four is the therapeutic use of the immune system in an attempt to eradicate tumors. Now, how would you differentiate a normal cell versus a tumor cell class? So please take note of the difference. In a normal cell class, the size would typically be small. They have a uniform and shaped nuclei. They have a relatively large cytoplasmic volume, uniform cell size and shape, organized arrangement of cells into tissues, normal presentation of cell markers, lower levels of dividing cell, and they have a clear demarcation. When you say clear demarcation, they have a clear outline. They don't have a fuzzy appearance on their outline. They have a clear, they have a smooth outline. So this is your normal cell. While a tumor cell class could be considered as a size of large, variable shaped nuclei, relatively small cytoplasmic volume. So they tend to have class a greater nucleus to cytoplasm ratio. Mas malaki, bigger class ang nucleus kesa sa cytoplasm. Variation of cell size and shape, disorganized arrangement of cells, elevated expression of cell markers, large number of dividing cells, and they are poorly defined. They have poorly defined cell boundaries. So that's the difference of your normal cell versus your tumor cell. So your tumor class could be subdivided into two types, your benign and your malignant. When you say benign class, they tend to become small, they are slow growing, non-invasive. When you say non-invasive, they do not spread. They are not capable of spreading. Let's say, meron kang cancer class sa buto. There is no possibility for it to transfer to other organs. They are well differentiated and they are localized. While malignant tumors naman class are considered large, fast growing, invasive, poorly differentiated, and can metastasize. So that's the problem with malignant tumors. And most of the time, class, kapag meron kang benign tumor, you just let it be. Hinahayaan mo lang. Some doctors would just say, hayaan mo lang yan, benign naman siya. But it's still recommended to remove it. But when it comes to malignant class, it has to be removed provided that it will not spread easily. Kaya nga kapag pag magkakaroon ka ng surgical procedure to remove a malignant tumor, the doctor or the surgeon has to make sure that the surgeon would completely remove all the infected tissue or organ. Why? Remember class, even if it's a small amount of the tumor remains, it can easily spread to other organs. That's the problem with your malignant tumors. They can metastasize and they are very invasive. And malignant tumors are divided further into carcinoma and sarcoma. Now let's start with the different tumor antigens class. So this is a very important part because this usually comes out in the board exam. So there are a lot of tumor antigens. Now your tumor antigens could be classified into many types. One of those is your tumor specific antigen, also known as your TSA. Now TSA class is unique to the tumor of an individual patient or shared by a limited number of patients with the same type of tumor. This is coded for by viral oncogenes, host proto-oncogenes, or tumor suppressor genes that have undergone genetic mutation. An example of this is yung PCR ABL protein, which is a well-known example of your TSA. So if naalala niyo yung BCR ABL na yan, that's a marker class for look for a type of leukemia. If naalala niyo pa kung anong leukemia yon, I hope you remember. If you're aware, yung CML. So it's found in your chronic myelogenous leukemia or your chronic myeloid leukemia. So in a BCR ABL gene, there's what we call a so-called translocation. So si ABL gene nyo class is normally found on the long arm. This is the long arm. This is found on the long arm of your chromosome 9. The BCR gene is also found on the long arm of your chromosome 22. Now here you could see in the picture on the left the ABL gene. On the right would be the BCR gene. Now what happens is that there would be a translocation. When you say translocation class, the ABL gene here will move or will be cut. It will be cut. It will be cut and it would be removed. And what happens next is that the ABL gene will attach to the BCR gene, forming a change chromosome 22. Let me repeat on that. Your ABL gene will translocate. It will attach through the so-called chromosome break. It will attach to the chromosome 22 where the BCR gene, causing the chromosome 22 to become the so-called Philadelphia chromosome. And the Philadelphia chromosome has the so-called BCR ABL fusion gene, which is a marker for your chronic myelogenous leukemia. So this is an example class of a TSA, a tumor specific antigen. Now there are also viruses class that could cause different cancers. And this was tackled, I believe, in your virology. One of those is your Epstein-Barr virus. Epstein-Barr virus class can cause a lot of cancers, specifically lymphomas. It's known to cause your Burkitt's lymphoma, Hodgkin's lymphoma, leiomyosarcoma, post-transplant lymphoproliferative disease, nasopharyngeal carcinoma. While your hepatitis B virus is known to your hepatitis B and C virus is known to cause hepatocellular carcinoma. Your human herpes virus 8, as you're aware, di ba maraming klase ng HHV. HHV 8 class is known to cause your Kaposi sarcoma. Human papilloma virus class is known to cause your cervical cancer, adrogenital and anal cancer, head and neck cancer. Your HTLV or your human T lymphotrophic virus 1 is known to cause your adult T cell leukemia or lymphoma, while your Merkel cell polyoma virus is known to cause your Merkel cell carcinoma, which is a type of skin cancer. So do memorize this class. This may come out in your quiz or exam. Then another classification, so we're done with your TSA. The next one is your tumor associated antigen or your TAAs. Now, TAAs class are expressed in normal cells as well as in tumor cells. Now, tumor cells would abnormally express this protein or carbohydrate antigens in terms of their concentration location, or stage of differentiation. So this one is a more or less specific class because they would uh, be produced based on concentration, location. TAA's class can be peptide, glycolipid, or glycoprotein antigen. Now, there are three major peptide TAAs class: the shared TSAs, differentiation antigens, and the overexpressed antigens. Let's start with your shared TSAs class. Now, shared TSAs class are expressed in many tumors but are not found in most normal tissues. So, they tend to be present only class in cases wherein there are tumors. You will not find them in normal tissues. Now, the only normal cells in which they have been detected are testicular germ cells and, to a lesser extent, placental trophoblasts and ovaries. The best known example of TAAs in this category are the melanoma antigen gene protein, also known as your MAGE protein, that are expressed by melanoma tumors. So one example of TAAs class that are shared TSA is the MAGE protein expressed by melanoma tumors. Then we have your differentiation antigens. These are expressed class on immature cells of a particular lineage. An example of TA in this group is the so-called CD10 antigen. So CD10 antigen class is an example of differentiation antigen. This category of antigen also includes the oncofetal or embryonic antigens that are normally expressed on developing cells of the fetus but are not expressed on the cells of adults. So if you find this oncofetal or embryonic gene antigens in adults class, there's a possibility that you have a differentiation antigens. Then the last one is the overexpressed antigen. So this is a type of TAA found in higher levels on malignant cells than on normal cells. Genetic mutations that would occur during transformation are thought to deregulate expression of these proteins, resulting in levels up to 100 times greater than normal. A well-known example of TAA that is overexpressed antigen is the so-called human epithelial growth factor receptor 2, or your HER2 protein. This is a transmembrane receptor that would bind human epidermal growth factor. Now let's go with the specific types of tumor markers class. Now, these are biological substances that are found in increased amounts in the blood, body fluids, or tissues of patients with a specific type of cancer. Tumor markers can be proteins, carbohydrates, oncofetal antigens, hormones, metabolites, receptors, or even enzymes. Produced by the tumor itself or by the patient's body in response to the tumor or related benign conditions. An elevated level of a tumor marker suggests that a significant amount of a particular type of tumor is present. So take note of this class. Kapag elevated ang tumor marker nyo, if the tumor marker class is elevated, it could signify or it could suggest that a significant amount or a particular type of tumor is present. Let's say an example ng tumor marker class, yung pinaka-common among men is the so-called prostate-specific antigen or the PSA. Sabi nila kapag ang PSA mataas, if it's increased, there is a possibility class that you could have prostate cancer. That is why ang ginagamit madalas, that's why in the laboratory, if you really want to find out if you have a type of cancer, provided that also other tests are in line or in coherence with it. Let's say mataas ang PSA mo, then upon checking your prostate really has a abnormal growth on it. Most likely you have prostate cancer. But again, class, this would require further testing. Pero best na ginagamit talaga is tumor markers. And these are the ones that would come out. in the board exam. Tinatanong to lagi. Now, what would be the characteristic of an ideal tumor marker class? So there are five. Be produced by the tumor itself or by the patient's body in response to the tumor. Be secreted into a biological fluid where it can be inexpensively and easily quantified. So it has to be secreted, class, in a fluid that can be inexpensively processed. And the best fluid here is always blood. Kasi blood, class, is readily available. And hindi naman siya inexpensive pag i-process. It should have a circulating half-life long enough to permit its concentration to rise with increasing tumor load. Increase to clinically significant levels above the reference value while the disease is still treatable. And it should have a high sensitivity and as well as a high specificity. Now, the detection of tumor markers class would provide an ideal way to screen for tumors because the markers can be detected by a simple blood test. Screening asymptomatic individuals can lead to earlier detection of tumors with a need for less aggressive treatment. The effectiveness of a tumor marker in screening for cancer would depend on the sensitivity and specificity of the marker, as well as the cancer's prevalence in the population. Now, to diagnose tumors, they would be useful or valuable aid in making a cancer diagnosis when they are used in conjunction with clinical findings and other tests. But they are not diagnostic class by themselves. That is why, as I mentioned in the previous slide, for them to be sure or for them to be accurate, you need to perform other tests. Then it can also be used class in assessing the prognosis of the patient. So a high concentration of tumor marker at the time of diagnosis or increasing levels of a tumor marker over time can indicate the presence of an aggressive tumor that has metastasized and would require rigorous treatment. Tumor markers can also be used to determine the type of therapy that would be most effective for a patient. To simplify this class, basically this would identify the stage of the cancer. Usually stage 1 to 4 lang naman yun. So if it's stage 1, well it's still possible to delay it with or to treat it with mild procedures, but if it's stage 4, you need to have a very aggressive treatment. So they use these tumor markers to assess the prognosis of patient. Then it would also be used class in monitoring the patient's response to treatment. So you would monitor whether their treatment is effective. So this can be done, class, because the level of a serum tumor marker often correlates with the amount of tumor in the patient. So to simplify this, class, kapag nakakita, let's say you had your PSA tested on April 1. On April 1, you had a value of 1,000 nanograms per ml. After 3 months of chemotherapy, drugs, and so on treatment, you had a test again on April, May, June. You had a test on June, or let's say July. From 1,000 nanograms per ml, it became 150 nanograms per ml. So this is being used, class, to check if the treatment is working. And in this case, since there is a significant decrease in the concentration of a tumor marker after the treatment, it indicates, class, that the therapy has been effective in shrinking the tumor. But what if naman, class, after testing on April, instead of having it lower when you have it retested at July, the levels became 2,500 nanogram per ml. If this happens, class, this could indicate that an increasing level of the marker would indicate that the tumor has recurred and it became and would require a more aggressive treatment. So that's one way. So I hope that was. Let's continue with the common tumor markers class. So here in this table, you will find the different tumor markers, the cancer they are specific for, their normal sources where they would usually be found, the non-cancerous conditions wherein they would be elevated. Now, just to make this clear, non-cancerous conditions class, as I mentioned earlier in the previous, there are some conditions wherein your tumor markers would be elevated, not just because of cancer. That's why you need to do further testing to verify or to confirm that the cause is actually a malignancy or a cancer. And here you would find additional comments. So let's start with the first one, the alpha fetoprotein or your AFP. Now, AFP class is specific for two types of cancer, the non-seminomatous testicular germ cell cancer and for liver cancer. AFP is well known for being a marker for liver cancer class. Now, normally you would find alpha fetoprotein in the fetal liver and the yolk sac and also in adult liver. Now, they become elevated in conditions such as your pregnancy and non neoplastic liver diseases. Comments here would include that screening conducted in high risk population for liver cancer, such as those with cirrhosis and chronic hepatitis. So, if you have cirrhosis or hepatitis class, you tend to have higher AFP. Now, in germ cell tumor, both AFP and your human chorionic gonadotropin are elevated. So take note of this class. For this to become specific for germ cell tumor, HCG or your human chorionic gonadotropin should also be elevated. Hindi pwedeng AFP lang yung mataas. Kailangan HCG din. Another marker is your beta 2 microglobulin. This is specific for B lymphocyte malignancies. This is a part of the class 1 MHC molecule. Elevated in inflammatory and high cell turnover conditions. When you say high cell turnover conditions, increase cell death, increase cell death, and that would lead to increase cell creation. Higher levels would imply poor prognosis in multiple myeloma. So take note of that. Then we have your carcinoembryonic antigen or your CEA. This is specific for colorectal, breast, and lung cancers, normally found in the tissues of the endodermal origin. Elevated in conditions such as renal failure, non neoplastic liver disease, and intestinal disease, and even age. Values are greatly increased with age and those who are considered smokers. Take note of that. Let's continue. Then we have your CA125. Now, CA125 class is specific for your ovarian adenocarcinoma. Normal sources would include ovaries and various other tissues. Non-cancerous conditions elevated in endometriosis, pelvic inflammatory disease, uterine fibroids, and even in pregnancy. Increases can occur during menstruation class. Screening is only recommended for women with a family history of ovarian cancer. So take note this class that during menstruation, CA125 is increased and screening is recommended if in the family you have a history of ovarian CA. Then we have CA15-3. This is specific for breast CA, pancreatic, lung, colorectal, ovarian, and liver cancer. Normal sources would include the mammary tissue, elevated in benign breast disease, benign liver disease. Now, take note, class CA15-3 is a monoclonal antibody directed against an epitope of epichalin. Then we have your CA19-9. This is specific class for the so-called pancreatic cancer. Normal sources, non-cancerous conditions elevated in benign hepatobiliary and pancreatic conditions. Can it be elevated in some non-pancreatic malignancies? Subjects who are Lewis A and B. So Lewis A and B negative persons cannot synthesize CA19-9. So take note of that, class. Your Lewis A and Lewis B negative people cannot synthesize CA19-9. Then we also have your estrogen or progesterone receptor, also known as your PR receptor. This is a marker for your breast adenocarcinoma. Normal sources would be breasts. Comments would include that and PR positive receptors, breast cancers benefit from estrogen or progesterone reduction therapy. Then we also have your human chorionic gonadotropin or your HCG, marker for non-seminomatous testicular cancer germ cell, tropoblastic hydatidiform mole, or your choriocarcinoma. Normal sources would include the placenta, elevated in non-cancerous conditions such as your pregnancy. Immunoassays that detect only intact HCG should not be used for tumor marker detection. In germ cell tumors, both AFP and HCG are elevated. Then we have your HER2 new or your new. This is for breast cancer. Normal sources class would include growth factor gene in all cells. Cancers associated with overexpression of HER2 or new have a good response to monoclonal antibody therapy, specifically yung trastuzumab. So take note of that. Then we have your prostate specific antigen or your PSA. This is specific for the prostate cancer. Normal sources is the tissue, uh, prostate tissue. Non-cancerous conditions with elevations would include UTI or prostatitis, benign prostatic hypertrophy. Levels are directly proportional to prostate size. Many elevations are benign or not clinically significant. Then we have your PTH and calcium or your parathyroid hormone and calcium. This is specific for parathyroid carcinoma. Normal sources is the parathyroid gland. So in cases of you have low levels of calcium, hypocalcemia, there would be increased PTH. So serum calcium may be high when PTH is elevated in parathyroid carcinoma. So in a normal in some diseases class such as your hypocalcemia. When you have hypocalcemia class, it is expected that you would have decreased calcium. And along with the decreased calcium, there would be increased PTH. But in conditions where you have parathyroid carcinoma, when you have parathyroid carcinoma, the opposite happens. Calcium is still increased, and along with that increased calcium, there would also be increased PTH. So instead na low yung calcium nyo class, you would have increased calcium here along with increased PTH. So just to clear ha, in conditions such as hypocalcemia, decrease ang calcium nyo, increase ang PTH. But in parathyroid carcinoma, you both have increased calcium and increased PTH. Now, PTH has a short half-life, so levels are done intraoperatively to ensure complete parathyroid tumor removal. Then we have your thyroglobulin. This is for your thyroid cancer. Normal sources is the thyroid. Now, thyroid globulin reflects thyroid mass, injury, and your TSH levels. Thyroid markers T4, TSH are generally normal in thyroid cancer. Often tested after TSH stimulation or less often by withholding thyroid medication to see if thyroglobulin production by residual tumor cells would occur. Now let's go to the different immune responses to tumors class. Let's start with your natural killer cells. Now the natural killer cell class is the key cell involved in the innate immune response to tumor. Please remember that. Sila yung responsible for the innate immune response to tumors. Now, tumor cells would become susceptible to killing by NK cell When they downregulate, when you say downregulate, they decrease the expression of class 1 MHC, or they upregulate expression of ligands that bind activating NK cell receptor. NK cells may also participate in antibody dependent cellular cytotoxicity, or your ADCC, in the presence of tumor specific antibodies. Recognizes glycolipid antigens because of their unique T cell receptor. This is the three processes wherein your NK cell would kill a tumor cell. So, in the first picture, the letter A, if class 1 MHC protein is present and there are no foreign or stress proteins, then an inhibitory signal is sent to the NK cell. So, this is your NK cell class. Then imagine in the target cell, there would be the presence of MHC class 1 protein. If there is an MHC class 1 protein and there are no foreign or stress proteins, then it would send an inhibitory signal. It would send an inhibitory signal to the NK cell, thus no killing would occur and the normal cell is released. And the second one, if infected cells may express foreign proteins on their surface that are recognized by an antibody, let's say here's your antigen class or your tumor cell. Now, your antigen or your tumor cell, when detected by an antibody, the antibody's epitope or the antibody's paratope or fab site will attach to the antigen's epitope. Itong nakikita niyong green na to. When that happens, class, it would allow your NK cell using its receptor, the NK cell receptor, itong red na to attach to the FC region. If naalala nyo pa dun sa mga previous module, di ba? And once that happens, class, NK cells would express CD16 receptors that bind the immobilized antibody. So magre-express siya ng CD16. Ito yon, itong pulang to. This is the CD16 receptor or the NK cell receptor. And it will immobilize the antibody and would activate the release of perforins and granzyme. So yung mga, di ba ang NK cell nyo is also known as the large granular lymphocyte. So yung mga granules niya containing perforins and granzymes will be released and it would target the antigen or the tumor cell, causing a programmed cell death or your apoptosis. So it would occur via either the mitochondrial or the cell death pathway. Then another pathway is itong letter C. If an activating receptor is engaged by a foreign or stress protein and class 1 MHC is altered or missing, let's say yung class 1 MHC mo dito is altered, nawawala, or missing class, then no signal is given. No inhibition. Walang mapupuntang inhibition dito. Then the granzymes and perforins are released and the infected or diseased cell is eliminated by apoptosis. So the NK cell could kill tumor cells class via your antibody dependent cytotoxicity or your ADCC. And this is done by this procedure, itong letter B, wherein the antibody would attach and ina-identify ng NK cell yung antibody. And another one is via the non-ADCC, which is this one. So I hope that was clear. Now let's go to another cell, yung macrophages nyo. So macrophages activated in vitro by interferon gamma have been shown to possess tumoricidal capabilities. Appears to kill tumor cells by the same mechanism they use to kill infectious organisms, including the release of lysosomal enzymes, reactive oxygen species, and nitric oxide. Produces tumor necrosis factor alpha, a cytokine that is thought to cause necrosis of tumors by inducing local inflammation and thrombosis in the blood vessel within the cancerous mass. Then you have your cytotoxic T cell, mediates the primary mechanism of adaptive immunity against tumor. So kung sa innate, Your case cell here is the NK. For the adaptive, it's your cytotoxic T cell. So take note of that. Now, CD8 positive T cell will respond specific for tumor antigens may require cross presentation of the tumor antigen by dendritic cells. Once activated, it will release perforins and granzymes, text peptide antigens. And we also have your helper T cell activated by dendritic cells by presenting tumor antigens in conjunction with class 2 MHC molecules. They play a role in tumor immunity by secreting cytokines such as interleukin 2 and interferon gamma. So ito yung process dyan class. So ito yung on the left here, you would see the NK cell. So ito yung entire process na kapag nag-ano ka ng tumor cell. So the first one is via the NK cell. So the NK cell could lyse the tumor cell via ADCC or via the simple process wherein there would be the there would be the inhibitory signal na mawawala, allowing it to release the granzymes and perforins. And your T cytotoxic cell, which is also responsible for lysing the tumor cell. Then you also have your APCs such as your dendritic cells, which along with the help of your T helper, the T helper will help in presenting the MHC molecules, allowing it to kill again the tumor cell. And we also have here your B cells that would become plasma cells uh, secreting antibodies that would allow the activation of your complement system, leading to lysis or apoptosis. So ano lang to class, parang diagram na pinagsama-sama yung lahat ng process on how tumor cells with the help of your NK cell, cytotoxic T cell, macrophages, and your T helper cells. And then how would the tumor cells or the different tumors class would evade the immune response? So ito yung sinasabi kaninang mechanisms. The first one is the active inhibition of anti-tumor immune response. So tumors would evade anti-tumor T cell response by engaging inhibitory molecules that would normally function to prevent autoimmunity or regulate immune response to microbes. Secreted products of tumor cells may suppress anti-tumor immune response. Regulatory T cells may suppress T cell responses to tumors. Myeloid-derived suppressor cells, or your MDSCs, are immature myeloid precursors that accumulate in the bone marrow, lymphoid tissues, blood, and tumors of tumor-bearing animals and cancer patients, and would suppress innate and T cell mediated anti-tumor immune response. Then another one is by the loss of tumor antigen expression. So despite the different mechanism by your immune system to attack tumors, cancer would occur at a high frequency in individuals who appear to be immunocompetent. This phenomenon has been called immunoediting, implying that the immune response directs changes in tumors that help them evade the response. Immunoediting is thought to consist of three phases: elimination, equilibrium, and escape. So let's tackle them one by one class. So sa elimination phase of the cancer immunoediting process is essentially the same as immunosurveillance. If the immunologic mechanism involved in immunosurveillance are highly effective, they will likely result in the complete elimination of the tumor. If the immune response are not completely effective, some of the tumor cells will remain in the body. And the immunoediting hypothesis suggests that these cells will then enter the equilibrium phase. Okay, so elimination class, basically this follows the rule of your immunosurveillance. In immunosurveillance class, if it's properly functioning, yung body mo has a good, properly functioning immune system, it can easily detect the complete elimination of the tumor. But not all of our immune system has a good immunosurveillance. And when that happens, class, the tumor cells will still remain in the body. And these tumor cells that were able to survive in the elimination process will now go to the second phase, which is the equilibrium phase. So ito yung punta tayo equilibrium. In this phase, class, tumor cells are thought to enter a state of equilibrium. When you say equilibrium, class, they are living together. They are in balance. They are in balance with the immune system, which keeps altered cells under control so they are not clinically evident. So basically, class, nagpapanggap yung mga tumor cells as cells that are not capable of causing diseases. During this period, class, tumor cells may remain dormant or evolve slowly over time. The dynamic interaction between the tumor and the immune system are thought to shape the phenotype of the tumor and its ultimate outcome. Hence the term immunoediting. As a result, class, the tumor may eventually be eliminated by the body, establish permanent residence in the equilibrium phase, or evolve into a phenotype that can escape the immune system and would cause disease. Mutations would occur in this phase in the genetically unstable transformed cells. Under selective pressure from immunologic forces of attacks by cells in the tumor microenvironment, some of the tumor cells may develop into genetic variants that are resistant to immune defenses. These cells would move past the equilibrium phase and enter the so-called escape phase. Now, during the escape phase, class, the balance between immunologic control and tumor development is now put in favor of the neoplasm or the cancer. So dito sa phase na to, class, hindi na siya nagpapanggap, mas ano na siya, mas malakas na siya. He has a stronger control over the immune system. So an example of this, tulad dito, some cancer cells would downregulate the expression of tumor antigens or MHC molecules on the cell surface, making them less likely to be recognized by T cell. So during this phase, class, some tumor cells would downregulate the antigens and the MHC molecule, making them unable to be recognized. Then some tumor antigens may be also be masked by glycoproteins and glycolipids on the cell surface, making them inaccessible to the immune system. Some tumor cells have impaired cell surface binding to perforin or have defective apoptosis-inducing receptors such as your FAS. Tumor cells can secrete immunosuppressive substances or can recruit T regulatory cells, myeloid-derived suppressor cells, or macrophages that produce cytokines such as transforming growth factor, beta, and interleukin 10, which can inhibit protective immune response. Now let's go to the immunotherapy for tumors. The goal for immunotherapy, class, has been to harness the ability of the immune system to destroy tumor cells. Immunotherapeutic methods can be classified into three major types: active immunotherapy, passive immunotherapy, adoptive immunotherapy. These are the three: active, passive, and adoptive for your immunotherapeutic method. Let's start with your active immunotherapy. Now, this began when William Coley performed the first systematic immunotherapy by stimulating the patient's own immune system to respond to TAAs. He noted that cancer patients who develop an infection after surgery experienced tumor regression and had better prognosis than patients who did not acquire an infection. Coley developed cholestoxin, please take note of this, which is a mixture of your strep pyogenes and your serratia marcescens, which was used to treat patients with inoperable bone and soft tissue sarcoma. Since this toxin did not get good results, the FDA refused to recognize the formulation as an effective cancer therapy, and it became illegal to use cholestoxin to treat cancer. Then we also have your passive immunotherapy class. In passive immunotherapy, you would administer soluble components of the immune system to boost the immune response. So this time, class, you're going to make artificial, or you're going to induce, or you're going to not induce, you're going to introduce to the body artificial immune components such as your cytokines, monoclonal antibodies. So other would include hematopoietic growth factors, your GCSF, GMCSF, erythropoietin, interleukin 11, interferon alpha, and interleukin 2. And you also have your monoclonal antibodies, which have been directed against seven major categories of antigen. The CD antigens, the glycoproteins, glycolipids, carbohydrates, vascular targets, stromal and extracellular antigen, and the growth factors. Then the target of therapy, so these are some of your monoclonal antibodies class. Actually, madami sila, but I need you to memorize this in preparation for your exam and your quiz. So here you would find examples of different monoclonal antibodies, and they would have different targets of therapy and mechanism of action. So let's start with the rituximab. This is a monoclonal antibody directed against the CD20 antigen and B cell used to treat B cell neoplasm. Ang target ng rituximab nyo is surface antigens on tumor cells. And the mechanism is via opsonization, complement-mediated cytotoxicity, and ADCC. Then we also have alemtuzumab. It has the same target of therapy. So this is a monoclonal antibody directed against mature lymphocyte antigen, CD52, used to treat chronic lymphocytic leukemia, or your CLL, and T cell lymphoma. Same target of therapy, surface antigens and tumor cell. And we also have your panitumumab. This is a monoclonal antibody directed against the epidermal growth factor receptor, used to treat colorectal cancer. Then we also have your trastuzumab, a monoclonal antibody directed against HER2, used to treat breast and gastroesophageal tumor with overexpressed HER2. So both of these monoclonal antibody class would target cell surface receptor. They block the signaling pathways involved in cell proliferation and survival. Then we also have your bevacizumab. This is a monoclonal antibody directed against the vascular endothelial growth factor, used for treating glioblastoma, colon, lung, and renal cancer. Antigens involved in angiogenesis are its target of therapy. It inhibits the formation of blood vessels necessary for delivery of oxygen and nutrients to the tumor. Then we also have your ipilimumab. This is a monoclonal antibody directed against CTLA-4, or your cytotoxic T lymphocyte antigen 4, for treatment of metastatic melanoma. And we also have your nivolumab and lambrolizumab, monoclonal antibodies directed against the program DET1, used to treat melanoma, colon cancer, and other tumors. The target of the therapy of ipilimumab and nivolumab and lambrolizumab are molecules that block T cell activation and proliferation by binding to molecules on APC. It enhances anti-tumor specific T cell response by preventing T cell inhibition. And then we also have your brentuximab vedotin, an immunotoxin directed against the CD30 antigen, used to treat Hodgkin lymphoma and systemic anaplastic large cell lymphoma. Then we also have your trastuzumab DM1, an immunotoxin directed against the HER2 antigen for treatment of HER2 positive metastatic breast cancer. Its target of therapy is antibody drug conjugates immunotoxins directed against TSA. Mechanism of action class is delivery of potent toxic molecules directly to tumor cells. So please memorize all of this class. This may come out in your quiz and even in your exam. Then we also have your adoptive immunotherapy. So this is a type of immunotherapy involving the transfer of immune cells that was previously exposed to a tumor to cancer patients. Transfer of these immune cells is thought to be effectively assist the patient's body in eliminating tumor cells. So ito siya class. Basically, you're going to introduce different cells that have been uh, exposed to exposed to tumor cells. So the example of this class, you would get or you would excise the tumor from a tumor positive patient. Then you would fragmentize the different cells. Then you're going to culture this with interleukin 2. Now interleukin 2 class would activate the cells, and you would now perform an assay for specific tumor recognition. Hahanap ka ngayon ng cell na they would have the target for the certain cancer. Let's say ang gusto mong targeting cancer niya is liver cancer cells. So you're going to perform an assay and you're going to identify alin sa mga cell na yan, which of those cells would target liver CA. And after that, you're going to select them. Then you're going to propagate them. To propagate them, class, you would need a cell line. So you need a cell line to propagate them, and then once that happens, you're going to now to reinfuse them to your target patient. So that's your adoptive immunotherapy. So that ends your module 10. Thank you.